All right, continuing our journey through the social demography of health, we will cover age and race. Now, you may be asking yourself, Mike, why are they combining age and race into one chapter? They seem to be distinct subject areas. Well, the point the authors are trying to make, and it's a good one, is that when talking about health, you need to talk about it as a process, not just as a static thing, right? It's something that it develops over time. And when we talk about, that's the age part. Now, the race part is the point they're trying to make is that this racial disparities that we see is not just a constant thing. It's one of these things that develops again throughout the life course. And also, we'll mention that social class does kind of the same thing. Now, the big story here is that really, if you want to understand population health like this, you really need to understand that these things all kind of interact. Race, class, age, gender. To really understand, you have to understand that these things interact, and they kind of form again a constellation of factors that influence health. And it's not examining either one of them in isolation misses a big part of the story, and that's what they're trying to address by presenting you this chapter in this way. All right. So, without further ado, if I can get my there we go. We'll start off with the sociology of aging. It's a whole discipline within the discipline of sociology. It's a specialty area. It was mine, actually, when I was in graduate school. And the underlying idea is that aging is not just a biological process, that it has social and psychological elements as well. Your book goes into a little bit more detail about this, but the gist is that there are life stages, and at each age there are expectations, there are requirements, and the psychology that goes along with the changes in these stages as things go along, and how psychological elements can affect people. Psychological elements from childhood can continue to have effects through adulthood, and so on and so forth. And then these have social effects, and you get the idea. Also, the sociology of aging, these folks would point out that aging is not just an individual process. It's not just something people go through. They argue that societies age, or develop is probably another way to put it. Institutions age. Institutions being education, government, nonprofits even, any kind of organization. These kinds of institutions age as well. So let's talk about society's aging. We'll talk about the current cohort of the elderly. Now, this is the notion of population aging, right, or societal aging. And we'll start that conversation by talking about the folks who are old now. These folks are healthier, they're better educated, they will have more money than old folks in the past for a variety of reasons, right? Primarily, these life expectancies getting much higher. They increased 60% in the century there. The people are healthier in old age just because they're not dying young or being very sick young. They're making it old age in relatively good health. The current cohort of elderly, these are the baby boomers. They grew up during a time of prosperity. It was a good time to be born at that point. The internet's replete with pictures about these folks, about people born into this era, being able to buy homes on minimum wage salaries and that kind of thing. Of course, the minimum wage was a lot more back then, adjusted for inflation. But you get the idea. So these folks, again, they were born at a good time. They're more affluent, and a lot of them could expect to live past age 65. 80% of them. Now, they also have a lot of political clout, as I'm sure you are familiar, and they have the influence power to influence relevant legislation. You can see why any politician talking about cutting Social Security and or Medicare often finds themselves out of work, regardless of their political party. Now, although this group is healthier, they're going to place greater demand on the healthcare delivery systems because there's just so darn many of them. So many people survived old age, and they're still here. And even though the elderly rate their health is good, there is this deterioration of health that does accompany old age, which is going to result in a strain on, public monies. Now, going back to the idea about self-rated health, right? So you have this population, they say they're healthy, but whenever you ask anybody's health, and say you're going to write a survey and say, how is your health? Everybody rates their health relative to something else, right? There's no objective benchmark that most people are using. They compare themselves to other people who are similar in age and sex, right? People who are roughly your age, roughly your sex. How are they doing? How you compare to them? And again, it also shows really how health is kind of perceived really in a lot of ways as ability to function, right? If you consider the concept of disability, right? Disability being the mismatch between someone's physical capacity and the demands put on them by their environment, then you can see how this plays out with older folks. They have reduced daily activity, so their daily environment isn't as demanding. Therefore, their poor health isn't really viewed as a problem, right? If you can't walk a mile, but you never need to walk a mile, are you really disabled, right? And in their minds, they're not. If you don't have to do it, well, it doesn't matter that you can't. So that's the bit with age here. Self-rated health. We're going to talk about health and delivery systems now. Why is this an issue? Is because, again, we have this population aging business. Western countries, we're one of them, as well as developed nations in Asia, are experiencing a demographic shift. People are living longer, as we've established. The other part we haven't really talked about is people are having fewer children. The birth rates in these countries are below replacement level. Replacement level is, I believe, 2.1 children per woman of childbearing years, or childbearing age, right? Which I think they consider like 15 to 45 or something like that. The rate in the United States is 1.7, right? Which is, for those of you who aren't very good at math, that's less than 2.1. Then you go to a place like Italy, it's 1.2, about half of that. Japan's not doing much better. Germany, France is actually pretty close to 2, oddly enough. Not sure the story there. I'm sure somebody else could tell me. Great Britain, well below replacement level. So what you end up with, aside from the fact that the population is going to actually start declining after 2065, more importantly, what you end up with is this. Fewer working age people per retiree, right? It's a thing called the dependency ratio, right? If you have the number of people who are working compared to the number of people who are dependent on, well, those who are working, right? And the older the population gets, the bigger the proportion of your population are retirees, right? The fewer people you have to, pay for them. Now, this, coupled with the shift of responsibility from family to society generally for older folks, kind of compounds the issue. So there's a reckoning coming when it comes to paying for all this. Sorry for the bad news. So, sociologists, what do we've established as demographic things. What's the big picture here? And the big picture is they note that people's lives, ours included, are paired with changes in appearance and adjustments and differences in energy, right? Our physical changes, as we move through our lifespan, right? And so it's this notion that the social and the biological are very much linked. An attempt to really separate them is kind of an artificial thing. Our lives are tied to, our bodies in many ways, most ways. So that's life. And now that's the sociology of aging, right? Now we get to life course theory. So this is the idea that it's not, let's go over here. The social isn't just linked to the biological; it's also linked to the historical, right? The book they talk about in your text is this book called "The Children of the Great Depression," right? And in this book, written by a fellow named Glenn Elder, now the conclusions are a little bit dodgy. I'll be the first one to say this, but he made very good points, which was that the experiences that these children had, being children during the Great Depression, had knock-on effects or ripple effects in their lives throughout their lives. It didn't just go away. And it wasn't a matter of the being well off or not well off that really was the key factor here. It was more about how they experienced what was going on. Now, the important part of all that is that it links, again, people's biographies to the historical era in which they reside, right? Now, that brings us to this next theory, which is called cumulative disadvantage. It's a descendant of life course theory, and it theorizes that disadvantages, be they economic, racial, health, what have you, they actually begin in utero and continue to add up over the life course, resulting in widening racial health disparities. How does that have to do with life course theory? Well, the idea here is that being born, a member of a racial and ethnic minority in 1920 is different than being born in 1960, is different than being born in 1980, 2000, so on, right? And as a result, the patterns of these, disadvantages, or the acquisition of disadvantages that these folks go through vary according to their cohort. And it's not always better or worse, it's just different a lot of the times. Now, there's a kind of a corollary to this, which is the idea of cumulative inequality. It's the same idea of cumulative disadvantage. It's kind of an academic point, but it allows for improved economic status in middle age. What this one points out is it's the accumulation of inequality that causes the problem. So if you somehow manage to get yourself out of that trajectory and improve your economic lot in life, this can have it can kind of mute this cumulative disadvantage effect that had been going on prior. That's the idea there. Again, it's an open debate as to which one's which. There's actually a couple of other different types of theories. Of critical period theory is another one that's out there. But all of them add up to the same thing, and that is that the experience of being an racial and ethnic minority, or having a disadvantaged social class position, is a lifelong thing, right? And it affects the development of people, not just physically, but also socially, because, again, these things are very much linked, right? And so the research that's done, they found that race has emerged as a primary driver of health disparities in the most recent stuff. So we should talk about race then. All right. So race, the convergence of biological factors, the geographic origins, and multiple cultural, economic, political, and legal variables. That's actually the real definition of it. Now, the social and behavioral sciences, which is what we're doing here, we view race mostly as a social construction, not really a terribly meaningful biological construct. There should be a little asterisk by that. There's some exceptions, but by and large, we find race to be important to study. We think our hypothesis that race is important because, again, race is central to identity. And so because of that, people have organized the social world according to race. We'll get myself into trouble here, but it's been a historical process, right, to, again, have this racial hierarchy. Again, it was written into law for hundreds of years here. And there you go. So race being central to identity, it's hard to really understand America without understanding race. Everybody has a racial identity, whatever it may be. And this identity affects behaviors and a host of other things, and that's why race is important. Now, when we talk about race, we're going to talk about racism, and we're also going to talk about economic disparities, but we'll start with racism here. So racism comes in two flavors. Right? You have interpersonal racism. This is the one you probably think of when you think of the word racism. This is saying racist stuff to each other or being racists, right? It goes everything from microaggressions to slurs, to calling police for watching birds, whatever it may be. This is interpersonal, right? This is just treating each other crummy because of race, right? And this is linked to hypertension, diabetes, and a host of other maladies. Right, so it's not to be mitigated. It's not to be minimized. Right. That said, a lot of the research most research has been done that has shown the biggest results, or most consistent, robust results, have been the ones that have been using the second definition, which is structural racism. Now, structural racism doesn't mean that the whole structure is full of racists. Actually, it means exactly the opposite of that. Structural racism is the idea that the structure itself is designed in such a way that it favors one ethnic group or minority, or one ethnic group over another ethnic group, right? The old textbook example of structural racism is, say, a guy builds a hotel, and this guy just hates disabled people, right? He refuses to put wheelchair ramps in. It's all stairs. It's blind turns. There's no braille anywhere. It's a rough scene for anybody with a disability, right? And, that's awful, right? We can all agree with that. That sucks. It's not a good way to be. The old guy dies, and then say you buy the hotel, right? Hey, you want to be a hotelier, right? So you're going to buy this hotel. Now, say you're operating this hotel now. Now, do you have a problem with disabled people? Well, of course not, right? You're not an animal, right? You have no problem with disabled people. But your hotel is still built that way. So even if you don't have the intent, the structure is still there that has this effect, this discriminating effect, right? Now, because of that, right, structural racism generally tends to focus again on class circumstances, material circumstances. And the important point here is that racism, socioeconomic status or class, and health are all interconnected. All right, so the U.S. has gone from a biracial black-white racial configuration, that's mostly what it was in the early 20th century, to really a triracial configuration of black, white, and Hispanic folks, with Hispanic folks actually being the largest minority population. All right, so black Americans, again, if we're going to understand the economic and health outcomes here, we need to understand the context of U.S. history. Again, I'm not saying this to make anybody feel bad, just saying the history. Slavery and segregation was the law for, 3/4 of U.S. history at this point. So because of that, and the fact that social and economic marginalization did not end in 1969 with the Civil Rights Act, we have these, again, long-term effects on, ultimately, wealth is really the big thing. Incomes are lower for black Americans for sure, but wealth is absolutely lower. Wealth is, things you own minus your debts, right? And a big part of that is housing. The black population is much less likely than the majority population to inherit a home or to have an inheritance when their parents pass on, right? Because, again, where would their parents get it from, right? These are folks who have made their money in the 60s, 70s, 80s, so on and so forth. And you see during that time, these folks weren't allowed to really make a lot of money. So they've had a lot less time to accumulate this wealth. Now, what's this have to do with health profiles? Well, black Americans have higher rates of mortality pretty much at all throughout the life course and through for most of the main causes of death than white Americans, except for pulmonary diseases, interestingly enough. Now, earlier onset of many diseases with greater severity and progression, more likely to have multiple illnesses at the same time, and ultimately have higher rates of disability. Now, the current trend is for increases in life expectancy to increase for this group, and actually it's been the most rapid in the past 2 decades for black Americans, particularly black women. In the last 20 years, the life expectancy has increased primarily because of improvements of death rates from cancer, improvements in infant mortality rates, lower suicide rates, and lower homicide rates, right? Now, the white Americans' gains in longevity, white Americans have also gained, but it's been limited by increases in deaths from drug overdoses, liver disease, which is caused by alcoholism, and suicide. So, before I mentioned the role of hypertension, right? I mentioned that biology is a social construct, and I said there should be an asterisk by that. Well, here's where the asterisk would lead us. There is a biological component when it comes to hypertension. More blacks than whites have hypertension, period. And that's controlling for everything. Money, jobs, you can name it. The rate is still higher. And there's a lot of reasons that are suggested for this. There's a genetic predisposition. You can see I have little stars next to it. That's because that one has pretty good research to back it up. And there's other theories that are out there that have less research to back them up, like this one, the physical exertion one. More likely than whites to be engaged in manual labor. Well, that's not it. Associated disorders, the idea that you're more likely to have other diseases that cause hypertension. No, that's not it either. The next one, psychological stress from discrimination. That one has some evidence too. Dietary patterns, poor medical care. Dietary patterns there's some there, but it's a hard one to measure, to be honest with you. And poor medical care, again, there is some research out there again, but that's actually a little old. So I had to put stars next to it. So the health disparities between blacks and whites point to, again, this importance of socioeconomic factors, right? You can see here, the genetic predisposition, can't do much about it, but psychological stress, yes. So, kind of sum this up, poverty, marginal unemployment, low incomes, segregated living conditions, inadequate education, all these are more common among blacks and whites, and are features of socioeconomic stratification, which has been known to cause poor health. We covered that in the social class chapter, right? So, black Americans have the highest all-cause mortality rate. Right? If you take all the causes of people dying, African Americans have the highest one, followed by American Indians and Alaska Natives, then non-Hispanic whites, then Hispanics, then Asians. Now, the higher mortality rate for most common causes of death, Black Americans have a higher mortality rate for most common causes of death, again, except for other than pulmonary diseases and suicides, which those would be non-Hispanic whites who have the highest rates for those, pulmonary diseases and suicides. Now, Black Americans, even though there are improvements in this number, still have 2 times the infant mortality rate of white Americans. Now, if you remember from our chapter on epidemiology, right, infant mortality is one of those measures that's kind of this catch-all measure of the overall health of a population, right? So the fact that the infant mortality rate for this group is 2 times that suggests that the overall health of this population is certainly much worse than that of the majority white population. Now, research consistently finds the culprit here to be higher likelihood of Black Americans to be living in poverty, right? We've already said this, but I want to repeat it in case it was missed. And now when we say living in poverty, we mean everything that entails. It's not just money to buy food or whatever, or to even go to the doctor. It's also the neighborhood you live in. The way schools are handled there, policing, all kinds of stuff. So while race does have an independent effect, i.e. racism and discrimination does have an effect on health, it's dwarfed by the effect of social class. And social class, again, is largely predicted by race. So you can see the logical chain there. Now, there's also other things of current research people are going into to try to find some of these health disparities. There are cultural food preference issues that don't necessarily have anything to do with money. It's about what people like. That's a whole field of sociology, by the way. What they call it, the field, the production of taste, right? There's a famous French sociologist, it's not a quiz or anything, but it's a famous sociologist, Pierre Bourdieu, who wrote all about this stuff. And the idea is that these cultural food preferences, for whatever reason, and we could go back into the history books and dig this out, but the more affluent, the things that they think are good or tasty or actually desire are better for them than the things that the poorer folks think are good or tastier that they desire, right? So that's a tough thing. That's a tough nut to crack there. You're trying to get people to eat things they think are gross to feel, make them healthier. It's not an easy task. Now we have neighborhood characteristics as well, and these neighborhood characteristics are thought to lead to higher rates of obesity. The idea being that the neighborhoods aren't safe to walk around, get exercise in. It's not anything you want to hang out in, right? Causes sedentary lifestyles and voila, obesity. And here's a big one, actually, is the lack of specialists in areas where Black Americans live. It's an important point. We always talk about healthcare as if it's kind of a one size fits 5 units of healthcare here will make the situation better. It depends on what the healthcare is. Going back to the infant mortality rate, one of the reasons why that mortality rate is so high is that rural Black women who live out there, rural women who live out in the country, there's no OBGYNs there. There's nowhere for them to have their babies. They have to drive 40, 50 miles into a town to get prenatal care and to even have their baby delivered. So, and because of that, the poorer folks do that less because that's difficult. You have to have a car, you have to get over there, go to your appointment, come back, be able to take the day to do that. Not everybody has those kinds of flexibilities. And again, it's not because there aren't doctors where they live. They have an emergency room. I mean, you get shot or you're run over by a car or something, they can patch you up. But they don't have OBGYN. They don't have open heart surgeries. They don't have like the laser knife brain surgery or any of that other good stuff, right? It's just bare bones unless they drive into the town, which, again, not everybody can do. All right, so that's Black Americans. We're going to cover the next 3 Hispanic Americans. Then I believe it goes to Native Americans and then winds up with Asian Americans. Now, Hispanic Americans. An interesting little tidbit about this group is this thing called the Hispanic paradox, which is that this is a population that is poorer, much more economically disadvantaged than their white counterparts, yet they have lower mortality rates at most ages. So there's a lot of explanations for why this could be. One of them is that the population is younger than other racial groups because of them largely being immigrants, or not them largely, but because of the large number of immigrants that comprise this population, recent immigrants. People who go moving across borders, right? These don't tend to be your old and frail folks, right? These are usually young, healthy people looking for work, right? And so because you have this influx of young, healthy people, right, coming for work, and these folks are going to test out as not having a whole lot of health issues because, again, they're like in their 20s and 30s and they're healthy, right? And so they're younger. That's one reason for it. There's other ones too. It's a question of diet, and so on and so forth. But again, it's one of these things that kind of go against the grain here with, more likely to be without a regular source of healthcare, which is usually a big predictor of mortality also. But not for this group. Now, it's not all puppy dogs and rainbows. Hispanic Americans do, in fact, live longer, but experience the onset of physical decline, i.e. disability, physical disability, earlier than their white counterparts. Now, an important caveat to all of this, and I'll just make the same caveat when we go over to Asia here in a moment. Hispanic covers a wide range of people, right? You have Cuban Americans, for example, who have health profiles that are similar or better than non-Hispanic white Americans, right? They have lower mortality rates, lower disability rates, the works, right? Puerto Ricans, on the other hand, have the worst health profile among Hispanic Americans, and it kind of is not all that dissimilar to the health profile of Black Americans, right? And again, why is this? And a lot of it has to do, again, with historical and structural and economic circumstances. Go take the Cuban American example. This is a group who immigrated to the United States with the United States' blessing, as one of those middle finger to the Cold War kind of things. And the folks that came over weren't the poor and the desperate necessarily. A lot of these folks were, the people who flee whenever the communists take over. The people who have money, right? If you own stuff, you have money, the communists take over, you bail, right? So they did. And so they didn't come to the States with nothing, right? And then they formed this diaspora. And then even when the poorer members of their society come over, this diaspora is already set up. And the community is there, and it fosters economic growth, which fosters health, and voila, right? Puerto Ricans, on the other hand, are a territory, right? They're not immigrants at all, but they're a territory that's largely neglected by the U.S. government. And they don't have the wealth and resources as that Cuban Americans have, period. All right, which brings us to Native Americans, right? Again, now, Native Americans have a pretty rough health profile too, but it should be noted that this group has experienced a significant improvement in their overall level of health in past decades. But important problems remain. In particular, there are higher rates of, this is a selected list, there's a full list in the text. Cancer from smoking, that's the big one. Any population that has high rates of smoking, that's not good for their longevity. If you learn anything from this class is, if you smoke, please stop. And if you don't start. You have diabetes and comorbidity from diabetes. Now, this is more common amongst certain groups of Native Americans, as you'll read in your text. Because again, Native Americans aren't a uniform group either, right? There's many groups, tribes, what have you. There's accidents. Again, it's kind of tied to drinking as well. Alcoholism, alcohol-related diseases, suicide. Now, the suicide rate is higher, and it's also, tragically, suicide at younger ages. White folks are usually take the crown when it comes to suicide rates, but the white folks who commit suicide are usually over the age of 45, right? Native Americans who are committing suicide are between the ages of 15 and 45, primarily. So it's different, right? Not to say that any life is worth more than any others, but I think you get my meaning. Now, Asian Americans. Now, again, big place, right? Asia has everything from Japan to Lebanon, right? Turkey? I don't even know. Roughly 2/3 are from 3 origin groups in the United States. Chinese Americans, historically, have been here for some time, actually. Indian Americans and Filipinos, right? Now, overall, Asians and Pacific Islanders are the healthiest racial group in American society when mortality rates are considered. You look at every number right now. The leading cause of death for Asian Americans is heart disease, but their rate of death from heart disease is lower than everybody else's. So, and why is this? It's an open question. It has a lot to do with diet, familial support, and some things I think we're not all that clear on. Now, they do have issues. I mean, nobody's walking around life, thinking, man, I got this stuff figured out. They still suffer from, this population, a lack of healthcare coverage, a lot of times due to recent immigrant status. Also, too, a lot of independent business owners who make too much money for something like Medicaid, but not enough money to really be able to afford care, so they kind of skate along. And of course, there's language barriers also. It's a steeper learning curve trying to go from an Asian language to English than it is pretty much anything else. Take it from somebody who's an English speaker who tried to learn Chinese. Yeah, my GPA never recovered. So again, this demonstrates the importance of socioeconomic status, right? Asian Americans have the highest levels of income, education, and employment of any racial and ethnic minority in the United States, even more so than even the white population on some of those metrics. And so it follows that their health would be good. All right, so in the end analysis, what this is all about is the thesis is generally that one's racial and ethnic status or group status has a big predictive effect on overall socioeconomic status, right? And that overall socioeconomic status has a big effect on health. So ergo, race has an effect on health. As far as age has to do with all of this is something that happens throughout the entire life course. From lack of prenatal care before being born to questionable nutrition during early childhood, poor education during adolescence, leading to substance abuse in early adulthood, lack of career options, poverty, despair. You got it, right? And that's what the life course sociologists were so helpful in pointing out to us. So if you have any questions, feel free to email away and make sure you do your reading. Till next time.